In behalf of our team, we'd like to thank everyone who took their time to attend our first MPPI webinar series. I would like to congratulate the brand managers who have organized this activity and also to thank our speaker, who I will introduce later on, Dr. Robert Buenaventura. As healthcare workers, we are acutely aware of the anxiety that's being generated by the current pandemic. As we start opening our clinics, either physically or virtually, we have to assess and make sure that the psychosocial issues that our patients are facing are identified and properly addressed. Today's webinar will help you in this aspect. To introduce our speaker, some of you may know our speaker. He graduated his pre-medical degree from the Far Eastern University, magna cum laude, Bachelor of Science, major in clinical psychology. Then he took up his medical degree from the University of the East Ramon Magsaysay Memorial Medical Center, College of Medicine, my institution also. He also had his residency training in general psychiatry from the same institution. Then he had a postgraduate training in psychiatry of old age in Sydney, Australia. And currently he is a diplomate of the Philippine Board of Psychiatry and a member of the board of directors of the PPA. He is currently the consultant psychiatrist from the UERM Memorial Medical Center and also the head of the Department of Psychiatry from the Manila Theological College of Medicine. Just to before our speaker begins, just to give you some background. So the presentation will last around 45 minutes. And you see on the right side of your screen, there's a chat box there. So I encourage everyone to write their questions while the presentation is ongoing so that you can, I can copy your questions and then give them out at the end of the lecture of Dr. Benaventura. We also will have a survey. I hope we will find times around the 5 minute, less than 5 minutes, 1 minute survey so that we can serve you better and so that we can come up also with more ideas as to what to present in our next webinar series. Okay, so without further ado, may I present Dr. Benaventura.
Mabuhay at magandang hapon po sa inyong lahat. I'd like to thank Multicare for this opportunity to talk to you about a very interesting topic. And especially I'd like to thank Dr. Luisa Bola for the invitation and also Mr. Edward Ginto, who's facilitated everything. I'd also like to say hi to all my colleagues and even medical school classmates who are listening right now. Okay. So this topic was something that was asked of me actually when my classmates and I were talking about the psychosocial impact of the COVID pandemic among our patients. Okay. Let me start off with the case of the Sleepless Chief Operating Officer. He's a middle-aged male, a widow with an adult son. He's the managing partner of an erstwhile successful retail business that has come to a halt since the lockdown. He was referred by his cardiologist due to difficulty in sleeping and had already been prescribed an antihistamine for insomnia, but with little effect. History taking showed that there was a major shift in his daily activities because before the lockdown, he used to work for about 10 to 12 hours a day. And since the ECQ, he was barely working, particularly because the office had been closed, the projects have been stopped, and therefore there was very little for him to do. Mental status examination revealed that he had very prominent concerns over his employees' welfare because they had about 30 to 40 employees at the time. He also had uncertainty over the company's future and also a very prominent worry over his financial status because he was already dipping into his savings to be able to continue providing for his employees. Okay. So my objectives for this afternoon would be to discuss important causes of the psychosocial responses of our patients to the COVID-19 pandemic and to share some strategies to help our patients cope with the psychosocial impact of the current crisis. Fear, worry, and anxiety are very common responses to a major health crisis, including the COVID-19 pandemic, together with known psychological reactions such as stress, loneliness, and even agitation. just for the purposes of this lecture, I'd like to make some differentiations or distinctions among these three important terms: fear, worry, and anxiety, because we, in usual language, in layman's terms, we generally interchange them, but in clinical settings we tend to differentiate one from the other. But for the purposes of this lecture, we sort of would consider them all together. Fear, as you know, is a psychosocial, an emotional response to something, to a threat that's directly in front of us. So if you have a rabid dog or a snake in front of us, then that would be fear, because there is an apparent danger. Worry, on the other hand, is primarily in terms of our cognitive aspect. So these are repetitive negative thoughts that keep coming back into our minds. For example, if you're a parent and you have a daughter who works as a nurse in the emergency room right now, then you'd constantly worry about her safety in her line of work. And then finally, there's anxiety. This is sort of the umbrella term for all of these things. Anxiety is sort of combination of our worry and our stress responses, mga physical or physiological responses natin to stress. And then, but one differentiation between anxiety and fear is that anxiety is usually something, a response to something that's vague, but it's still very pervasive. Okay, so it's different from fear, which is apparent. So with anxiety, it's something that is not directly or clearly apparent, but it's still something that bothers or makes the individual very concerned. Okay, so those are the common responses that our patients will feel. A very recent cross-sectional study in China found the overall prevalence of anxiety, depression, insomnia had increased compared to prior to the pandemic. Anxiety to up to 35%, depression up to 20%, and insomnia up to 18%. Particularly for anxiety and depression, in which the baseline prevalence for China was in single digits. Now it had magnified to more than 3 or even 4-fold the usual prevalence. And so we would expect that the same thing might be happening in our situation right now. So these psychological responses can lead to adverse long-term consequences. So if this persists, this could lead, and these are just some of the adverse long-term consequences, such as deterioration of social relationships. Particularly, I've already had some consultations in which individuals, for example, let's say spouses who have been in lockdown for the past 2 months, sometimes it can create some friction in terms of the relationship. We've also seen a lot of stigma and rejection, particularly affecting our frontliners. There's also anger and aggression. There's a lot of blaming and towards, for example, our government officials. And then finally, people can develop mistrust and paranoia, not just for government officials, but maybe for each other as well. And there's a group of people that may be more vulnerable to this, and so therefore their responses may be more magnified. So as we know, this would include older people and people with chronic diseases, frontliners, no? Like us, like doctors and other healthcare workers. And then finally, particularly from my perspective as a psychiatrist, people who have mental health conditions may be more vulnerable as well. In pre-pandemic situations in our clinical practice, we already know that as much as 25 to 30% of adults consulting medical practice may have a diagnosable mental condition, such as anxiety or depression, although it's associated with low recognition or referral rates. So therefore, we might expect that the same thing may even be increased during this time. Therefore, it's very important for physicians to develop a high index of suspicion, which will be beneficial to the patient, particularly those with pressing concerns about the current situation. So why are they anxious? What can explain all these anxieties? Well, first thing is we must remember that a lot of these fears and reactions spring from realistic dangers, but many also come out due to other reasons, which I'll enumerate one by one. Okay. Number one, of course, because we're in a situation in which there's a highly infectious disease, there's a repetitive thought that we or our loved ones may get sick. Okay. And therefore, there's also uncertainty about their future, particularly when the lockdown occurred. What's going to happen to us? As you've noted in the case that I mentioned earlier of the COO, he was very uncertain about the future of his company, what's going to happen. So people particularly will be concerned about their jobs. And this is in relation to the next one about financial concerns. And this affects a lot of people who are in a no work, no pay situation, which interestingly may include a lot of physicians who are in private practice, because as you know, if you don't practice, if you don't see patients, then you don't earn for the pay. So there's a lot of financial concerns as well in terms of what the future may bring. Now, the next one, overwhelming amount of information. This is very common, and therefore, this is actually one of the top reasons why people are very anxious nowadays. No, there's a lot of information coming from mass media, social media. A lot of it very repetitive. There's a mixture of fake news with factual information, and then misinformation, and even sensationalism from the mainstream press. So this creates a lot of confusion in the minds of our patients. And then next one is there's no prior experience with dealing with the situation. I mean, unless you were born in the 1900s, no, in which and you survived the previous pandemic. But for most of us who are living right now, this is the first time that we're going through this situation, and therefore we really don't know how we're going to respond. So we oftentimes, particularly including our government officials and or let's say the people that we work for, okay, they're dealing with the situation on a day-to-day basis, and at times their decisions may not be correct or good, okay, but we oftentimes may need to learn from our mistakes. Other reasons include the following. There's stigma and rejection. I've already mentioned this briefly earlier. And initially, this was affecting patients with COVID-19, but also we're seeing that it's affecting our healthcare workers as well. And therefore, if this could affect even doctors and nurses, then it could affect anyone. Okay. People feel powerless, helpless, and hopeless at this time because there's a lack of control. We've lost control over the situation. We're told to do this, we're told to do that. Okay. And oftentimes we just have to follow, even though we may not fully understand what's going on. People have developed paranoia, especially when you hear about news that there are a lot of asymptomatic people who can still pass on the disease. So people can become very concerned and may be a reason for them to become very paranoid, particularly with strangers. And then finally, there's isolation. And this can happen to anyone. When the lockdown started, for example, specifically in Luzon, a lot of people were unable to go home to be with their loved ones. So they had to stay put, particularly in the places of work or in the places where they were staying in temporarily. And therefore, this has created a situation in which they felt very isolated and away from the people whom they loved and who usually would provide support for them. So these are some of the things that we would need to look for. Okay. We also see that our patients may have other manifestations. Okay, as I mentioned earlier, they may primarily come to you for somatic manifestations like vague aches and pains, feeling of lethargy or tiredness. Okay, and then like with our case earlier, okay, he may feel something because I have also a patient who complained of chest heaviness, but it turns out it was more in terms of anxiety. That came primarily from because his father died from rheumatic heart disease, so he associated that thing to a cardiac disease. They may also present with sleep difficulty, just like our case, difficulty in initiating or maintaining sleep, and oftentimes early morning awakening as well. They may have changes in appetite. We usually see insomnia. We usually see anorexia, but patients may present atypically with increased appetite as well. And other emotional reactions can include irritability, impatience, and anger, okay, which can lead to a lot of blaming and scapegoating. We ascribe blame to others over the situation, okay, rather than blaming ourselves. A lot of it is because of the frustrations that we feel, and oftentimes we are unable to vent or express these frustrations towards others. Okay. People can also feel sad or lonely. I'm not using the word depression here, but sadness and loneliness are normal, usual terms that we can use for feelings that can reflect how we're responding to the current situation. At the other end, there are individuals who become very apathetic or detached. They become socially withdrawn. They do not interact with others anymore. Some people may develop negative coping behaviors. That's an oxymoron, negative and coping, because ideally when we say cope, that means to be able to deal effectively with the situation. But others are trying to deal with the situation in a negative way, like they binge drink or take illegal drugs. People may manifest with poor functioning, affecting their self-care, their relationship with others, and their capacity to work. Others may involve in risky behavior, such as particularly illegal behaviors, like people who were making fake quarantine passes. Okay, and then finally, there's denial. A lot of individuals are denying. Okay, an interesting aspect about risky behaviors. You've also seen this happening in the U.S. as well, and then to a certain extent in a situation, because, for example, like when ECQ became GCQ in some areas, you saw a lot of people converging in malls, and all aspects of social distancing flew out the window. So that's an example of risky behavior. Because the last one is denial, because a lot of people are afraid to admit to themselves that there is something going on that can affect them. So rather than face the truth of what's happening, then they'd rather deny it. And as a result, this can lead to all the other manifestations that we've already listed. Okay. So how can we help our patients cope with their anxieties? So I'm talking primarily of patients who are consulting in a non-psychiatric situation, okay? Presenting primarily with medical concerns. So what can a doctor do? It's important to let our patients know that it is normal. The WHO has said that all these emotional reactions can still fall within a normal range. So it's common for people to feel distressed during this crisis, and we need to remind them that there is nothing wrong with asking for and accepting help. Okay. And another important strategy that we can employ is oftentimes you can just listen to them reflectively, okay, because they simply just need to be able to express or vent the fears that they have. I mean, after that, they're usually more likely will be okay. Okay, but it's important that they will be able to bring it out into the open. And usually, as you know, looking at the doctor-patient relationship, patients usually ascribe a lot of trust to their doctors. They look up to their doctors as a figure of authority. And therefore, when a doctor gives them advice, then patients generally follow that because they have an understanding that it's going to be very helpful for them. So aside from this, what are the other things that we can do? Okay. These are practical tips that I call them practical tips, but because these are things that we already know. Sometimes we're already doing this, but it's often still necessary for people to remind us to do this. For if someone tells us you need to do this, especially if I'm a patient and my doctor tells tells me you need to do this, then there's a higher likelihood that I'll follow. Very basic number one is practice self-care. Being able to eat right, hydrate, sleep well, exercise, and maintain proper hygiene, and and to be able to comply with their medication. So if they have hypertension or diabetes, then they need to ensure that they're taking their medications correctly. Next one is to focus on timely and accurate information from reliable and credible sources. As I mentioned earlier, one of the main reasons why people become anxious is because there's an overwhelming amount of information that confronts them. So it's important that they will focus only on credible or reliable sources like the WHO or the DOH, okay, and then limit to, let's say, a highly credible news agencies like let's say GMA or Rappler, so they can limit their sources to just a few. I mean, they don't have to read everything. And that dovetails to the next practical tip, which is to limit mass media and social media exposure. I've often recommended this to a lot of family and friends and my patients as well, is that instead of checking their mobile phones like every 5 or 10 minutes, like to put it aside and just look at it like 3 or 4 times a day. It may be very difficult for millennials, but for middle-aged and older adults, it's much easier for them to be able to follow that. Okay. And then next is they need to educate themselves and follow recommendations. So by this time, everyone should already know how to be able to wash their hands properly, how to sanitize their hands, following recommendations such as staying home or social distancing. And it's very important that it remains in their minds no matter what happens, because we know that's very critical and very helpful. This is also an important strategy, for them to be able to reach out and connect with family and friends, including those who are isolated. So if you know someone who's isolated, then reach out to them. But for our patients, we need to let them know that one good source of emotional support would be our loved ones, our family members. So it's important for them to be able to reach out to the people who love and care for them. And next one is to engage in enjoyable activities, like hobbies and crafts. I know that there's a lot of, for example, free online courses that they can take. There's actually a lot of things. Uh, a colleague was telling me the other day when we were talking about this that she realized that there was so much that one can do. Okay, it's just a matter of being able to look into those possibilities. Next one is they need to be able to think positive, be positive, act on things that they can control. Because as I mentioned earlier, one reason for their anxiety is people often feel very powerless about the situation, particularly mga breadwinners or heads of families. No? And because they're usually the ones that will be beset by so much concern and worry over supporting their family members. So it's important, therefore, that they maintain this positive attitude. It would also help to do the next one, to make decisions. So on a day-to-day basis, we can make decisions about what's going to happen to us, especially if you're working from home as well. I mean, for doctors, we can make a choice as to when, because I'm doing a lot of online mental health counseling now. So I can make a decision as to when I can see patients. So with our patients as well, we can help them understand that they can make decisions on certain aspects of their lives about what they're going to eat the next day, what they're going to wear, what they're going to do. So help them develop a plan, draw up a schedule. And then, but the next one is important as well. They may develop a routine that will help them deal with the day-to-day activities of daily living, but they need to be spontaneous as well. So, which means that although they may have a schedule, that they can take a time away from that and, for example, be with someone that they love. They need to be productive. They can help other people. They can volunteer. They can donate or share. This is important as well particularly because it improves our sense of self-worth. So our patients may be able to feel more useful at this time if they can do this. If they can reach out and help someone else, if they can share their resources, then that would be great. Now, this one is very critical. This is because this dovetails into an aspect of what we refer to as mindfulness, to increase their self-awareness. Particularly, this is something that I recommend to my patients that they can do at the end of the day, just before they sleep. Have a quiet time so that they can pause and listen and monitor their thoughts, feelings, and actions. Try to understand, for example, look back in terms of what has happened during the day, and then go over that in their minds, and then try to make solutions or resolutions about stuff that need to be resolved. So a quiet time, just a 5 or 10 minutes, just by themselves, can be very helpful for them as well. And then finally, let's help them look for someone that they can rely on. So as I mentioned, one person that our patients usually look up to would be their primary physicians. But there are others, like parish priests or other relatives, because it's important to have these trustworthy individuals who can provide advice, guide, help, and even listen. Because listening is such a simple strategy, but it's immensely very helpful. In fact, when we talk about psychological first aid, the very first step of providing psychological first aid is reflective listening. So lending an ear to someone who's in distress can be extremely helpful. Now, the last four tips, I'm talking about them separately, so it may be applicable to some. What I mean is they may not be applicable to everyone. And the next one is prayer. So a lot of people really feel good about praying. They can pray in the silence of their hearts together with their loved ones or in one global single voice. Because prayer to some extent can be like meditation. It can provide a calming, soothing effect on a lot of individuals, particularly those who are beset with a lot of fears and anxieties. It's also important to be kind, to show compassion towards others and also to ourselves, to themselves. Okay, because a lot of people may feel guilt, but it's important at this time not to do that, but rather to feel that sense of kindness towards oneself and others. And this one I like particularly. Laugh. Find the funny in everything. This will help break the cycle of negativity. So if there's a lot of concerns, I mean, they can just browse through YouTube. Or I have a patient who's done that as a lot, because he said it helps him get distracted from the worries that besets him. And then finally, we can find meaning. Finding meaning can be done like today, like it's something that they can do today, or something that may come later. But it's already been 2 months since we've had the ECQ, at least in Luzon. So therefore, a lot of this has given us the opportunity to think about the situation. What does it mean to us? So finding meaning is simply trying to come to grips, or a good understanding about the situation and how it's affecting us. Okay. So when to refer to a psychiatrist, because of course what I've given to you previously would be something that you can do with your patients, how to help them. But there may be times, that you may feel better referring a patient to a specialist. Now, of course, when referring to another specialist, we need to consider the dynamics of the doctor-patient relationship. Okay, and of course, referral to another physician is certainly the prerogative of the primary physician. And of course, would be based on good clinical judgment. Okay, because what patient will look at their first physician, especially if this is a patient that you've been seeing several times already. You've already developed a very good or solid doctor-patient relationship. But let me just go through something in terms of issues of referral, because there are some patients who don't like, or who refuse being referred to another specialist, or specifically being referred to a psychiatrist. No? Because we know there's a huge social stigma of being a psychiatric patient. That's why a lot of patients, when they're told that they need to be referred to a psychiatrist, they may refuse. Okay, and the referral to a psychiatrist may damage their self-esteem. And one reason for this also is because a lot of patients do not understand the role of of emotions and how it connects with their physical state. And then finally, the patient may feel rejected. Does my doctor do not like me anymore? That's why he or she is referring me to another one. Okay. So, but of course, a lot of patients, like for example, the COO that we talked about earlier, okay, he didn't mind. He actually welcomed the referral to a psychiatrist, because his cardiologist was able to explain it very well why he needed to be referred to a psychiatrist. No? Because by the time, after about 2 months of insomnia, the patient did feel that, that he didn't think that it was going to hurt to be seen by another doctor, at least get a second opinion. So we need to consider this when referring a patient to a psychiatrist. Okay, so well, the question that faces you now is, how do you know it's beyond normal? So how do you know it's time to refer the patient? In my situation, I always look at the patient's overall functioning, and this would be divided into three. Number one would be personal function, which refers to self-care, their ability to take care of themselves, dressing up, eating, sleeping. Okay, and then there's social function, which refers primarily to their interpersonal relationships. Occupational function, affecting work or school performance. So if any or all of these areas are affected, like they don't sleep anymore, they don't eat anymore, they don't interact with people anymore, they become socially withdrawn, staying in bed the whole day, they are unable to focus on their work, or they're unable to do their school assignments. Okay, so then there might be a likelihood that their manifestations, or whatever they're feeling, may be going beyond normal. Okay, so another aspect that you would need to consider would be also the extent and severity of the manifestations. The other day, an obstetrician friend of mine asked me, about the patient who had insomnia. Okay, when should you just use this form of treatment, and when do you use this other form of treatment? Okay. And then when do you, for example, can you just prescribe, or do you need to do psychotherapy as well? So it was a very interesting and complex discussion, but we generally would take it on a case-to-case basis, because as you know, our patients are individual human beings, and therefore their responses and their thoughts and feelings are different from each other. So what are the other resources? For example, if you don't if the patient doesn't want to be referred to a psychiatrist, or I mean, even you don't think it's not that serious anyway, there are other resources that the patients can follow. But just let me start off with telemental health resources, because these are the ones that we're using right now. For example, at UERM, where I primarily practice, all the private clinics are still closed at the moment. Okay, it might open next month. So in the meantime, me and a lot of my colleagues are using online resources. So in my situation, I use CUSMD and Recovery Hub. So a lot of you may be familiar with CUSMD, but Recovery Hub is primarily used by psychiatrists, no? Because it's owned by a psychiatrist and devoted primarily to psychiatric patients. So these are telemental health resources that the patient can utilize at the moment if you feel that there's a need for them to be seen by psychiatrists. But if not, there are other resources. There are other, for example, crisis hotlines. There are several crisis hotlines that are available right now, but one of the better ones is the National Center for Mental Health Crisis Hotline. The numbers are there. There are globe lines and then landlines. No? I was talking to our top NCMH officials a few weeks ago and was asking about this hotline because I know that a lot of people are utilizing it. They said at the time, at the start of the pandemic, um, it, the number of calls relating to COVID-19 made up about 60% of their total daily calls. No? So on a day-to-day basis, they would have at least 200 callers. The good thing about this NCMH crisis hotline is that it's free, it's confidential, and the operators, the people who respond to the calls, are trained counselors. Okay, I mean they don't just answer the phone; they're actually trained to deal with the callers. Okay, and if they feel that there's an additional support that's needed, then they schedule the patient to talk with a psychiatrist eventually. Okay, so this is a good option that you may consider for your patients. Okay. Other ones, there's these other two. There's several, as I've mentioned. For example, the Philippine Mental Health Association and the Psychological Association of the Philippines are also doing phone counseling. But these two are the two of the first that came out. No? The first one by UP Diliman Psychological Service, and the second one is from our association, the Philippine Psychiatric Association. However, in this situation, the patients do not your patients may not be talked to right away by a trained professional. They need to get an appointment or a schedule. So at UPD Psych Serve, a psychologist will talk to them. In Mind Matters, a psychiatrist will talk to them. Okay, we do get a lot of calls already. So this may be something. This may be resources that the patients might benefit from. Okay, if you feel there's a need for this. Okay, so that was quick. So now I'm going to go into my conclusion. Okay. I'd like to emphasize that really there's no health without mental health. So when we're talking about our patients' health, mental health should be part of that. And in fact, our mental hygiene mantra is this Latin phrase, yung mens sana in corpore sano, a healthy mind in a healthy body. And which means we also need to consider that in a pandemic, in a crisis situation such as this, no, mental health should already be factored in at the start. That it's a service that will need to be provided. It's not something that the government will think of in the middle or at the tail end of the crisis. But at the start when people are planning for resources to provide to patients, that mental health should already be topmost. Okay. And then we need to understand that your patients will present with medical concerns, but at the back of their minds, there will be psychosocial issues concerning the pandemic. And thus, we need to provide a more holistic approach towards patient care. And with that, I'd like to end my lecture. But before that, these are my references. And to thank everyone for their kind attention. And I guess I'll turn it over back to Dr. Abola for the Q&A. Marami pong salamat sa inyong lahat. I'm happy to note that I have some psychiatric colleagues who have also joined the webinar, so they can also give this lecture themselves. So, pag hindi ko masagot yung tanong, I will call on them. Dr. Papa, Dr. Magallanes, Dr. Buot.
I mentioned that I am a volunteer in the DOH COVID hotline. and a lot of patients call in and complaining of really somatic symptoms, no, headaches, body pains, inability to sleep. So I think that really is a problem in the in these times, no, right? No.
Right. Oh, it's very common. Even before, somatization is a very common the coping mechanism of individuals. So um, there's a saying again, sorrow that is not given vent in tears will make the body weep. So people tend to express their emotional reactions through physical manifestations.
Okay, so I have several questions. I'll just bring it up.
Yep. Yung
Okay,
madadali lang, Dr. Abola.
yeah. So you mentioned already about one was asking when do you refer to psychiatry, and aside from the usual alarm signals like hallucinations, are there other alarm signals to look for that will make you decide that you have to refer to a psychiatrist?
That's a very good point, no? Particularly about the psychotic symptoms like hallucinations and delusions. But of course, from a psychiatric perspective, another one would be suicidal ideations or suicidal attempts, or if the individual is becoming aggressive towards others, no? Particularly because if let me cite several instances because the other day, yesterday, another doctor was talking to me about violence or abuse because we know that in other countries that has increased
The issue.
significantly. Okay, because of the lockdown situation, we assume that it's also happening to our situation right now in the Philippines. But unfortunately, we don't have data as yet. So aggression towards others will also be a reason for referral.
Okay, another question is all right. Uh, how can doctors, frontliners deal with burnout, especially during these more challenging times of COVID pandemic? Because it is tiring both
Oh.
physically and emotionally, and you still have to go to work. You know, you have to report daily, and you know you're faced
Mhm.
with all of these issues.
Right.
So
So
any
yeah, thank you very much for that. We actually that was di ba, another thing that we were thinking of talking about, no, yung burnout with the frontliners. But we felt we should start it focusing on our patients first, because there's the totally different approaches between dealing with frontliners and dealing with patients, especially with frontliners. There's we we would we suggest something what we call psychosocial processing for one thing, because I'm going to talk about our experience at UERM right now. So the Department of Psychiatry at UERM has is instituted what we call psychosocial processing for frontliners in the university hospital. Okay, so they are able to schedule group sessions. But there are those who prefer to talk on a one-to-one basis. Uh, and that this is very important because remember one of the first reasons that I cited earlier about the reason for anxiety, you thinking that we or our loved ones can get sick. I mean, that's
yeah, that's right.
paramount in the minds of a healthcare
Yeah,
worker as well, diba? Every day that you go to the hospital, to the emergency room, there's at the back of your mind, am I going to get it?
that's true.
So it's important. So I would suggest that if they know psychiatrists, or if they're in a university hospital setting, then work with the Department of Psychiatry in the hospital that they working in to be able to, because I know the Department of Psychiatrists in all major hospitals already have psychosocial processing programs in place, like just like
Of
what we're doing at we are.
for the frontliners.
Right. For yeah,
Okay.
that's focused for frontliners. Yes.
Okay. So I've been receiving several questions about insomnia because that's I think that's a very common symptom, no? Difficulty of sleeping. How do you deal with this? Do you give already sedatives, hypnotics for them to able to go to sleep or what? Or when do
Mm.
you decide to give them sedatives?
Right. The first thing that we would do is do a sleep assessment. No? In my case, I would ask them to complete a sleep diary, or if time is rather short, then we do a very comprehensive assessment as much as we can. For example, like the case that I cited earlier, it was not just a matter of switching his antihistamine to a benzodiazepine. It was important. It was critical that they have a good understanding of why he had difficulty in sleeping. So as we know, there were two significant changes. Number one is in terms of his activities of daily living. Number two was in terms of his mental state, because we need to be able to address both. Because just prescribing a hypnotic drug may not be sufficient in the long run. Both may be both would need to be addressed as well. So that's what I would do first. Okay. And fortunately at UERM we have a couple of sleep specialists now. No? So if the problem is of insomnia is really very disturbing, then they could go to a sleep specialist.
Okay, so are there any more questions? Because I'm not seeing questions anymore in the chat box.
Oh,
Okay.
so
Do
dagdagan
you?
ko na lang muna
Sure, sure.
sige. Dagdagan ko na lang
No.
yung sa kasi I guess yung isang concern nila about the prescription of sleeping pill,
Mm.
no. So I still see a lot of not a lot, but I still see several patients who come to me who are taking Iterax. Okay. So kasi
Okay.
when I do the review of medications, I say, oh, they're taking Iterax. Sabi ko, bakit may allergy kayo? Anong
Wala.
makati sa inyo? Hindi
That's
ako
correct.
pampatulog ko yan.
Yeah, that's true.
Okay. Okay. I recently had a patient who was given Sleepacil, and then sabi ko, okay. So they're taking a lot of antihistamine. I mean that's fine if the patients respond to that. But I think in the long run, there are better alternatives. For example, yung mga non-benzodiazepine hypnotic agents, no, they may be helpful as well. You usually would and then also a common concern kasi is that what if my patients get addicted or become dependent on these medications? Okay, on a short-term basis, treatment of insomnia, on acute insomnia particularly on a short-term basis, will be safe. As long as you use the drug judiciously at the right dose. For example, like zolpidem at 5 or 10 milligrams at night, okay, and then can be tapered off later on. So as long as you use it judiciously, then you should not be afraid, because even with other benzodiazepines, no, the ones that are available now are very good. They're very potent, and that's why we can use them at a very low dose. No? Kasi dependence and usually tolerance can occur when you're taught you're taking the medication at high doses in particular.
Yeah. Uh,
I'd like to
how?
make a
Oh,
mention, Louis. I'm sorry.
yeah, sure.
Can I greet Dr. Des Rodriguez and the UER Department of
I
Psychiatry?
saw I saw the mention
Did you see
also.
that?
Yes, yes.
Okay.
What in these times now where we have virtual clinic, how do you think patients are they accepting this type of consultation right now? Telehealth, telemedicine, virtual clinics.
Oh, we were talking about this the other day. Surprisingly, it's actually very it's very helpful for psychiatrists and our patients, because a lot of our interactions are primarily discussing and talking. Okay, and therefore consulting online is actually very helpful to us. The main challenge that we have right now would be in terms of our digital infrastructure. But other than that, the patients so far that I'm seeing online, they're fine with it. And I'm seeing a lot of older adults. I mean, my practice is
Mm.
geared towards geriatrics, and they will have a younger member of the family come in and
Mm.
help them set it up,
Set up.
and then bahala na yung nakakatandang pasyente.
Yeah. There was some one comment about a while ago about listening that you mentioned, about listening to your patient, and also notice this when I answer the hotline, most of them just feel relieved that they were able to talk to a health professional. And I think that's very important. As you mentioned, listening and mindful listening, really.
Right. Yes, that's true. Because anyone, all of us naman, even on a casual basis, we prefer to talk and have someone listen to us rather than to listen to someone else, di ba? Okay. So that's why if someone is beset with concerns or fears and anxieties, yes, of course, being able to talk about one reason din kasi is that, and then yung what I mentioned earlier, what the first thing, what can a doctor do, yung reassurance to the patient that what they're feeling is normal or common, because our patients are going through this uniquely as well, diba? This is the first time they're going through this, and now they have a lot of these anxieties and fears. So that now they're thinking, is something wrong with me? So when they bring it up into the with their doctors, and the doctors say, oh, no, it's all right. What you're going through right now is very common. Other people are going through that. I mean, that's very helpful. That's very reassuring. Okay, and we know that for us because we have studied on this. Okay.
Well, someone mentioned it about exercise, other physical
Yes.
activities may
Mm.
relieve also anxiety, even for some doctors, right?
Yes,
So,
I totally I totally agree, and that's the reason why for the case that we presented earlier, we needed to look in terms of his activities of daily living as well. Okay, but the challenge that I have, and this was a concern that was raised by families as well because of the lockdown. Unlike before when they could walk the streets as
walk out,
let's say
yeah.
30 or maybe for 30
Yeah.
minutes walking on, of course they cannot do that because in some barangays, particularly they're overzealous sabi natin barangay tanods or policemen. Pag nakakita sila ng matanda, pinapauwi nila sa amin na bawal ho sa inyong lumabas, not knowing, may mga guidelines about that. So what happens to a lot of elderly people in particular? No, they become terribly housebound. Then they cannot
Mhm.
go out. So for the younger adults that
Yeah,
who
yeah.
can, then that's good. No, that's why I agree. No, you continue. That's part of the sleep hygiene techniques that we would recommend. No, increasing physical activity, minimizing daytime naps. No, and again, ito may
Mm-hmm.
coffee. Caffeine is not an
Mm-hmm.
absolute contraindication for insomnia because it depends on your level of tolerance. No, some people can take 4 or 5 cups of coffee a day and still sleep like a baby at night. No,
Yeah.
but of course we're probably babies. But the thing is, there are those if they take just half a cup, they get stimulated. So we need to see first the level of tolerance of the individual towards caffeine before we can make recommendations whether they need to stop it or not.
Yeah. Well, someone mentioned about anxiety creeping, not only patients, of course, as you mentioned, to doctors. No? I mean, that I think that is truly the case. As you mentioned, it's not only being afraid about you getting the COVID, but you may be bringing it to your houses and to your relatives, especially if you have senior
Yes.
citizens at home.
Oh, right, right. And I've seen like in a lot of doctor Viber groups, because I'm a member of like what 4 or 5. There's a long, repetitive discussion about what they call antiseptic mats, about HEPA filters, about because this I guess a doctor's way of dealing with the situation cognitively, it, dealing with this intellectually, because I know that all of us will have those fears as well. What if I bring this home and infect others, especially my loved ones? So that's why we need to discuss this and bring it out into the open. Okay.
Someone's question about the S2 licenses. I know that DOH allowed e-reseta. They're allowing that now, so I'm doing that. But what about
Mm.
PIDEA? I saw a memo from PIDEA, but I haven't gone through it. Are they
Okay.
allowing
The latest.
e-reseta?
Yes, they're allowing S2. There was an earlier PIDEA memorandum about S2 licenses, so that's still allowed, but it's only good for a month. No, then unless the doctor makes several prescriptions, like 1 of 3, 2 of 3, and 3 of 3. So that means the prescription can be good for about 3 months. But then they had a follow up memorandum about that. So for doctors, so just a reminder to psychiatrists, no, for psychiatrists who have been prescribing S2 medications, we need to report those to their compliance office after the quarantine period. Okay.
Okay, thank you. So, any more questions? Are there any more questions for the group? And so, I'll give you a few minutes to think of your questions and to write in the chat box. For those using cell phones, there's a gray bar at the bottom of your screen that you can tap so that you can, and the chat box will appear. So, Bong, we have listeners as far south as Zamboanga City. Zamboanga, from Iloilo, from Cebu, Nueva Ecija, Cabanatuan, and
So that's
Bicol.
good. So we're covering Luzon,
Yeah,
Visayas, and
yeah.
Mindanao. I'm glad. So again, thank you to Multicare, Dr. Bola. Thank you very much. I think, well, personally, I think this is a good uh, topic to discuss. No, but I think we should also have a topic on the helping the frontliners.
Was a very interesting question. What can you advise to people wearing PPEs
Ah,
experiencing claustrophobia? Very good,
okay.
interesting
Yeah,
question.
very good question. Um, I'm 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 glad you mentioned that, because when we were viewing the process of donning and doffing, no, because may term pala yun, to don and to
Yeah,
doff.
yeah, yeah.
Okay, may proseso pala yan. So my suggestion, if you have some degree of claustrophobia, is to do it gradually, desensitize yourself. Okay, so rather than put it all at once, no, on one day just put the first layer, then after a few, so just use one layer first, and then, I mean, don't go out. I mean, don't yes, you need to desensitize yourself first. That means you tell your supervisor, you tell your boss, na I have this problem with the PPE. So can I do this first before I do a full metal jacket thing? Okay. So yun ang suggestion namin, gradual or progressive desensitization.
Okay. Oh well, a question coming from a primary care physician. If you don't have an S2, what can you give to patients? Probably this is referring to insomnia. I know the
Okay.
practice is to give antihistamines because, like diphenhydramine, for them to go to sleep.
Uh, so we shout out daw muna to Southern Philippines Medical Center Internal Medicine. They have 84 residents listening to the webinar right now. Okay,
Okay.
so hi. Um, so alternative to an
Yeah,
S2
yeah,
drug.
yeah.
I mean, um, my primary alternative is diphenhydramine. Okay, 25-50 milligrams. Okay. The interesting thing is there's a lot of low potency antipsychotic drugs that antipsychotic drugs and antidepressants do not require S2
Oh,
licenses. Actually, there are ordinary prescriptions. No? Okay, that's why if you go to the website of PIDEA, they have a list of S2 drugs, and you see that antipsychotics and antidepressants are not included there. Okay. What I would also use as an alternative would be a low potency antipsychotic drug, such as thioridazine or quetiapine
mm,
or
mm.
chlorpromazine. So if you're a physician and you need to prescribe a non S2 or non benzodiazepine hypnotic drug, then my suggestion would be either use an antihistamine or a low potency antipsychotic drug. If you're concerned about low potency antipsychotic drugs, just remember that they're low potency, and then you're going to use a very low dose. For example, like what I would use would be between 12.5 to 25 milligrams. Like thioridazine, I'm sorry, not thioridazine, levomepramazine or Nozina. Levomepramazine has a 25 milligram tablets. What I would usually start with would be one fourth to one half. Okay. And I use that a lot with elderly patients as well, and it's helpful, especially if I know that they may be taking the medication for a longer term period. No, so I would start with a low potency antipsychotic drug right away. But just remember, no, these drugs have very strong usual like dryness of the mouth, urinary retention. Okay, but
Okay.
if they're taking it at low doses, then generally they'll be tolerable.
Okay. Last two questions. Any views on melatonin uh,
Oh, okay.
for insomnia? In fact,
For sleeplessness.
yeah.
Okay. if you look at the indications for melatonin, there are only two. Okay. Well, actually, there's only one indication for melatonin for patients with insomnia, and that's for people with disrupted sleep schedules. So, to mind, there are two people who will have disrupted sleep schedules. Number one, yung mga shift workers like nurses, di ba? Number two would
Mm.
be people who fly different time zones
Yes,
like flight
yes, yes.
attendants. No? So for pag ganun na situation, then melatonin will generally be helpful for them. I also find that elderly patients may be helped as well. The reason for that is that a lot of elderly individuals have decreased melatonin secretion naturally. So therefore, if we give them exogenous melatonin, then it becomes helpful to them. So if you're not just able to sleep for some reason because you overslept the night, melatonin may not be helpful. No? So we need to stick to the main indications for melatonin. Okay.
Okay. Okay. So we're almost up now. But some question came out about pregabalin, gabapentin for fibromyalgia. Can this be given also for insomnia? Have you
Um,
encountered this?
I'm not sure, no, but I do have patients because I don't use it for fibromyalgia, but I use them a lot for pain medication. Okay, but my patients who are using it for pain have not reported any
Insomnia.
sleepiness. Okay, so I'm not sure if it's going to be helpful for insomnia.
Okay. So we have a question from a rheumatologist because most of his patients are her patients are of course immunocompromised and of course they're
Right.
anxious. So what
Mm.
how can she help them? I mean,
Well,
because
like
there
what
are
we mentioned
there
earlier, no, just inquiring. Sa akin, that's a good sign. The fact that you know that they're anxious, that's a good sign
Mhm.
because that already shows your compassion towards
Right,
them.
right.
So just bring it out. No, just ask them. Just a gentle question like, "I've noticed that," because a lot of times the patients may be hesitant to bring it up because they may
Mm,
be embarrassed to mention it to their
mm,
doctors that they're having difficulty sleeping. That they're afraid of the situation. No? So if you notice, like in this case, if this doctor has enough compassion to be able to notice that, then that means the next step would be to ask them about that. I noticed that you are somewhat anxious, no? May dahilan po ba? Okay. And
okay.
oftentimes
So
that can open the floodgates to the patient being able to talk about their concerns.
yeah, last question. Now we have all the time in the world. We're at home. Someone is asking, what is the healthy number of hours we should be looking at our gadgets, at looking at our apps? So, is there
Okay.
a number? How long should you be staying online?
Okay. Depende yan sa age, For example, for children and adolescents, may specific recommendations sa
Mm,
mga
yeah.
child and adolescent psychiatrists sa mga DevPeds about that. So, kung adults, okay, ganito ang magiging sitwasyon niya. This is how I'm going to. It depends on how disturbed you are. For example, if you keep, like what we mentioned earlier, you're always in your gadgets, but you're looking, always scanning about news about COVID. You're looking at the number of deaths. You're looking at the masks from China not working, and it bothers you. So if your interaction with your gadgets bothers you, then I would suggest limit it. Okay, but if it's not okay, sleep, yung blue light na
Mm, mm, mm,
tinatawag,
mm.
can
Yeah.
delay sleep latency.
Mm.
So I would suggest stopping using your gadgets about 1 hour before you plan to go to sleep, or at least put it in, I forgot, the dark mode or something like that. No.
Yeah, yeah. Okay, so thank you, Bong. Thank you, and also to our viewers who attended. So far, we've had up to a maximum of 500 attendees. We're down to 400
Okay.
right now. So thank you, Bong, and to very lively discussions and very interesting questions and a lot of insights. So before we end, may I ask our viewers to please answer a short survey flash on your screen so we know how to improve our digital campaign. We will also send the recording because we are recording the session, so you will receive a link so that you may watch this again at your fourth to learn more. No? Is knowledge on how to help our patients cope with the anxieties, the social issues that our patients and also our frontliners know how they'll be able to cope with all the anxieties and social issues that we are facing. So thank you to the brand managers team for the support, of course, for the leadership team for their counseling also and for their advice, and also for everyone for your time and effort to attend this event. Stay safe. Happy long weekend because Monday is supposed to be a holiday, and God bless everybody. Thank you.